Thanks, Dr. May. That was great. And I'm looking forward to the conversation about some of those data. I'm going to pick it up here. These are my disclosures, and I will point out I do consult for a couple of the companies for which I'm going to show data, so please keep that in mind. The overview here, I'm going to talk about what may be new in non-invasive colon cancer screening tests, as well as invasive screening tests. We'll talk about risk stratification for colorectal cancer, as well as colon cancer screening interventions. So starting with what's new in screening, we can start by talking about the comparative effectiveness of screening tests. As I mentioned previously, there have been very few studies with head-to-head comparisons of the impact of non-invasive versus endoscopic screening on the risk for incident and fatal colon cancer. And of course, our working hypothesis has been that endoscopic tests should be more effective than the non-invasive tests. These are among the first data that I've seen on this. The abstract was titled Colon Cancer Screening with Repeated Fecal Immunochemical Tests versus Sigmoidoscopy, Incidence and Mortality Follow-up of the Italian Multicenter Trials, and it was presented by Dr. Carlo Sonore. Their aim was to compare colon cancer incidence and mortality at 15 years follow-up among subjects enrolled in the FLEX-SIG and FIT arms in the SCORE-2 and SCORE-3 trials. So these are two randomized trials that have been conducted between 1999 and 2004 among people at average risk for colorectal cancer, age 55 to 64. And you can see on the right the schema for the SCORE-2 trial, where they offered a choice of FLEX-SIG or FIT, SIG plus FIT, FLEX-SIG only, or FIT. And then the SCORE-3 trial had a FLEX-SIG only arm, a FIT only arm, and then they also had a total colonoscopy arm. And what they did in this abstract is they restricted their analysis to subjects who were invited to undergo FIT every 2 years. That was about 24,000 individuals, or one-time sigmoidoscopy, so about 11,000 individuals, and they did not look at the group offered choice, combination, or total colonoscopy. Their primary outcome was colon cancer incidence and mortality through up to 15 years of follow-up. The FIT participation was about 30% in the first round, and at least once on follow-up for 50% of the individuals, and on average, they did about 3 FITs in the FIT arm. The sigmoidoscopy uptake or participation rate was 30%, and there was some crossover. So some of the sigmoidoscopy patients didn't do the SIG, but they ended up doing a FIT, but they are analyzed within the sigmoidoscopy group. These are the primary results for incidence and mortality, and the bottom line here is that exposure to sigmoidoscopy or being randomized to sigmoidoscopy was associated with about a 15% relative reduction in colon cancer incidence compared to the group invited to FIT. And then for mortality, the point estimate was also a relative 15% reduction in mortality, but this did not reach statistical significance. The implications here are these are among the first data comparing the impact of a strategy of FIT versus endoscopic sigmoidoscopy-based screening on incidence and mortality. It suggests superiority of endoscopic screening with respect to incidence, and we await the final report and the results from more ongoing studies. We touched on before the potential opportunity of blood-based screening tests, and I just want to take a moment to familiarize you with the approach here. So the idea here is that colon cancer tumor cells and maybe adenomas may shed DNA into the circulation, and that we can take advantage of advances in technology for sequencing and analyzing DNA. So this can be looking at fragmentomics, which is looking at the patterns of fragmentation of DNA, methylation patterns of DNA, and known changes in DNA that track with colorectal cancer. And we pull all this together to get a positive or negative result in terms of a prediction on whether the patient has colorectal cancer. And there are a number of companies that are working on assays that take advantage of this approach. This was a late-breaking abstract, a report of one of those studies. It's clinical validation of a cell-free DNA blood-based test for colon cancer screening in an average risk population. Their aim was to evaluate the performance of a cell-free DNA blood-based screening test in an average risk population. The population was defined as age 45 or older, presenting for a screening colonoscopy between 2019 and 2022 across 265 sites. The blood was collected pre-bowel prep. The primary outcome was colon cancer sensitivity and specificity, and the secondary outcomes included sensitivity for advanced precancerous lesions, which included conventional advanced adenomas, so size 10 millimeter or larger, villus histology, high-grade dysplasia, or sessile serrated lesion 10 millimeters or larger. They had an assay algorithm analyzing the DNA methylome and fragmentation patterns. This was locked pre-analysis, and the analysis was conducted blind to the case control status. They downsampled the entire study cohort of 22,877 individuals to identify all colon cancer cases. So there were 65 colon cancer cases, and then a random age and sex stratified sample of controls, which was 7,796 individuals. And here you can see the breakdown here, 65 with colon cancer. An analysis group included about 1,100 people with advanced precancerous lesions, and the rest basically had normal or minor findings, so non-advanced adenomas. The demographics focus on the second column, which is the evaluable subjects that they looked at. The average age was 60. The majority, 69%, were between the ages of 50 and 69. 53% were female. In terms of racial ethnic breakdown, about 7% were Asian individuals, nearly 12% Black individuals, and there was about 13% representation of Hispanic or Latino individuals. These were the top-line results. The overall sensitivity for colorectal cancer was 83%. The bars here on the side show you the stage distribution. So when we look at localized, regional, and distal, they got all the regional and distal and 72% of the localized. When we look at AJCC staging, it was a little bit different. There's more nuance here. So here they're also including malignant polyps, so cancers within a polyp, and the stage 1 sensitivity was 55% and then 100% for the rest. The specificity for the absence of colorectal cancer or an advanced precancerous lesion was 90%, and the sensitivity for advanced precancerous lesions, however, was only 13%. They did meet their pre-specified endpoints for colon cancer sensitivity and specificity. Here's the result of another abstract that's attempting to leverage this technology. This is large multi-cohort study, shows accurate detection of early stage colon cancer in advanced adenoma patients using cell-free DNA methylation and fragmentation signals. Their aim was to assess the diagnostic accuracy of a test utilizing DNA methylation fragmentation characteristics of selected cancer-related biomarkers, tumor-derived signal deduction, and a machine learning algorithm to refine a blood test for early detection of colon cancer and advanced adenomas. This was a prospective international observational case control study. The blood was collected either prior to colonoscopy or if they were undergoing surgery for colon cancer prior to the surgery. They had 170 early stage, 128 late stage colorectal cancer cases, 149 advanced adenoma cases, and 550 age, gender, and country of origin matched colonoscopy controls. 155 of these individuals had totally negative colonoscopies, 337 benign findings, and about 58 non-advanced adenomas. The panel of biomarkers was previously identified through tissue and plasma-based discovery and verification workflow. I will point out that the algorithm was not locked prior to analysis, so this really is a training analysis which tend to overestimate the performance. The primary outcomes were colon cancer sensitivity and advanced adenoma sensitivity, as well as specificity. And here were the main results. You can see here that the advanced adenoma sensitivity was 54%. The colon cancer sensitivity they reported was 93% and was high across all of the AJCC stages. And then in terms of the overall specificity, they hit 92%. So what are the implications here? I think we're likely to have at least one blood-based FDA-approved and Centers for Medicare and Medicaid Services covered test within the next 1 to 2 years, so this is coming. I will expect that the sensitivity and specificity for colon cancer will be comparable or better than FIT. That's what the first abstract I showed you was demonstrating. The adequacy for early stage colon cancer and advanced adenomas remains uncertain. So what could be the potential impacts? We could get increased participation in colon cancer as a result of the availability of this convenient blood-based test. There could be increased colon cancer detection. So even with a lower sensitivity for early stage colon cancer, you still might be finding more early stage cancers if a lot of people do the test. But there also could be possibly reduced colon cancer prevention if blood-based participation displaces participation in FIT, stool DNA FIT, or colonoscopy. At least for that first test I showed you, the sensitivity for advanced neoplasia was not very good. In terms of risk stratification, there were a couple interesting abstracts. This first one is the risk of advanced neoplasia after polypectomy in adults less than 50 versus 50 and older. These are data from the MGB colonoscopy cohort. The background here is that in our routine practices, we're often seeing and having detection of adenomas in people under age 50 who are undergoing routine diagnostic colonoscopy. It's unclear whether young onset adenoma detection confers increased risk for colon neoplasia. The aim of the study was to assess the subsequent risk of advanced neoplasia in patients under 50 who had undergone a polypectomy at their index colonoscopy compared to older individuals. This was a longitudinal cohort study of 188,000 individuals exposed to colonoscopy between 2007 and 2017 at the Mass General Brigham System. The primary outcome was advanced neoplasia, which they defined as colorectal cancer or conventional advanced adenoma or a 10 millimeter or larger serrated polyp. And this, they stratified the results based on the baseline colonoscopy finding. And the median follow-up was up to 5.7 years. So here are the top line results. So these are stratified by age less than 50 versus 50 and older. And the first column shows the risk for advanced neoplasia among people who had a baseline low-risk adenoma compared to people who were normal. And what you can see is whether they were younger than 50 or older than 50, there was no increased risk for advanced neoplasia on follow-up in this group. And then when you look at people who had baseline high-risk adenoma versus normal, you can see in both the younger and the older groups that there was about a 1.2-fold increased risk for advanced neoplasia on follow-up. The other point that's made in the graph is they're showing the risk of having an advanced neoplasia diagnosed on follow-up, and they're stratifying this based on the age greater than 50 versus less than 50, and also whether they had a baseline high-risk adenoma versus low-risk adenoma. And what you can see here is if you take the less than 50 group, their risk, whether they had a high-risk adenoma at baseline or whether they had a low-risk adenoma at baseline for an advanced neoplasia on follow-up, is lower than what was observed in the older age group. So the implication here is that individuals with young onset adenoma likely do not need more aggressive surveillance than currently recommended guidelines. We also just published a paper on this in which we looked at the risk for incident and fatal colon cancer after young onset adenoma diagnosis among US veterans. And what we showed was that the 10-year cumulative colon cancer incidence rates in people who, even if they had an advanced adenoma, was really low. It was 0.18%. So we don't need to be extra aggressive. The one caveat here is we have to take into account the rest of the patient's history based on whether they have a family history of colon cancer or whether we're seeing multiple and lots of large polyps. That would change my thinking about this. The other risk stratification abstract is this one, which is known colorectal cancer polygenic risk score is associated with baseline screening colonoscopy findings, but not follow-up colonoscopy outcomes. So the background here is that polygenic risk scores, which calculate genetic risk for colorectal cancer, may help prioritize individuals for more intensive versus less intensive colon cancer screening. And in theory, a polygenic risk score could be calculated based on a saliva swab sample or a blood sample. The aim here is to assess the association of a polygenic risk score with prevalent and incident advanced neoplasia in a population undergoing screening, colonoscopy, and follow-up. This was as part of the Department of VA Cooperative Studies Program 380 cohort, which was started in the late 1990s. They took a sample of individuals from this cohort with and without advanced neoplasia at baseline and follow-up colonoscopy. And the polygenic risk score, so they didn't invent this, they took a published polygenic risk score and basically applied it to the biospecimens that they had for this group. One of the main results for the whole cohort, if they look at increasing polygenic risk score, they found that this increased the risk for finding prevalent advanced neoplasia at baseline colonoscopy 5-fold. And for incident advanced neoplasia follow-up, it increased it about 2.6-fold, but it was not statistically significant. They did a sensitivity analysis to say, all right, well, what happens if you throw out those people who had a family history of colorectal cancer, and they continued to see a similar risk association. They then did a thought exercise at thinking about, well, can you use this score to sort of weed out people who might be very low risk for advanced adenoma, and the people who are higher risk could go on to have a colonoscopy. So when they look at this strategy where you would send anyone with a quintile 2 or higher polygenic risk score to colonoscopy, they found that this was about 92% sensitive for finding individuals with advanced neoplasia, and it might reduce the proportion of people who would need a colonoscopy by about 16%. So the implication here is that polygenic risk scores may have a role in risk stratification. We might be able to use them to help us triage which patients for whom it might be safe or safer to use a non-invasive test versus colonoscopy. And it might also help us triage people under 45 who right now wouldn't be eligible for screening based on family history. It might help us pick out which ones might need earlier initiation of screening. I'm going to close by presenting one of what I thought was the best studies presented at DDW. This was also a late-breaking abstract, and this was led by Dr. May, and I hope I can do it justice. This was titled "The Comparison of 4 Population Health Interventions to Increase Colorectal Cancer Screening in Young Adults, Results of a Randomized Trial." And so the background here is that screening is newly recommended for people age 45 to 49, but the best strategies for getting rapid implementation and uptake in this group that's newly eligible remain uncertain. Their goal was to compare 4 different outreach strategies to maximize screening participation among people age 45 to 49 in a diverse health system. This included UCLA Health patients who were age 45 to 49 who had an assigned primary care clinician, and they randomized 20,509 people to one of 4 groups. So either they got an opt-in FIT invitation, so an option to request a mailed FIT, a opt-in colonoscopy invitation to request colonoscopy scheduling, a choice to opt in to get a FIT kit or to sign up for a colonoscopy, or mailed FIT outreach where we sent them a mailed FIT kit, and this was considered the standard of care. All invitations were sent to patients via the electronic patient portal and received 1 initial text message and 1 reminder text message 2 weeks later. And the primary outcome was completion of any colorectal cancer screening at 26 weeks. And compared to most colon cancer screening trials, this is a pretty short window to observe outcomes, and to me makes the results all the more impressive. And here are the results. The overall completion rate, so among people who were not up to date at baseline in terms of getting them to participate in screening, was an impressive 18.6% in this group of 20,000 individuals. So really amazing just right there. And then as we look at the data broken down by group, the opt-in FIT group, the participation was 16.4%. The opt-in colonoscopy group, it was 14.5%. For choice, it was 17.4%, And then for the mailed fit outreach, it was 26.2%. And this was higher than any of the other groups on the statistical comparison. So in summary, I've shown you that emerging data suggests endoscopic screening is superior to non-invasive screening. A novel blood-based test with performance similar to FIT are likely to be approved within the next 2 years. Individuals with early onset adenoma detection on incidentally detected early onset adenoma do not require special follow-up beyond current guidelines as long as they don't have other modifying factors. Genetic-based risk stratification strategies are promising for risk stratification, and the best way to get newly eligible people age 45 to 49 rapidly up to date may be to offer mailed fit. Thank you so much.